Today we'll focus on the pathophysiology, clinical identification and diagnostic considerations when you encounter a pulsus bigemini. I am Dr. Neeraj. First of all, what is pulsus bigemini? Pulsus bigemini, also known as a coupled rhythm, is an arterial pulse profile characterized by pairs of beats grouped together, followed by a distinct pause. So unlike a normal regular pulse, the bigemini pulse wave exhibits a repeating pattern of volume asymmetry. The cycle begins with a normal or dominant beat, which is a regular sinus beat with a normal stroke volume. This is followed immediately by a premature beat, which is a closely coupled weaker beat with an abruptly small pulse amplitude. Finally, there is a distinct compensatory pause that occurs after the second beat, which is the premature beat. And then this is followed by a normal next sinus beat cycle that sets in. To understand the pulsus bigemini, you must look the relationship between an electrical timing and the mechanical output. Specifically, the interplay of ventricular filling time during the diastole and subsequent stroke volume. The classical mechanisms are derived by premature ventricular complexes alternating with a normal sinus beat. So initially the sinus beat fires normally, generating a normal ventricular contraction. An ectopic ventricular focus then fires immediately, prematurely, soon after the sinus beat. Because the second ectopic beat occurs early in the cardiac cycle, the ventricle has had very little time to fill during the diastole, and according to Frank Starling's law, this reduces the end diastolic volume, and subsequently a weaker contraction happens. So because the ventricle is relatively empty when the premature beat, that is the second beat, occurs, it operates on a tiny stroke volume, and in severe cases the stroke volume may be so small that it may not open the aortic valve to produce a peripheral pulse. So this creates the illusion of a drop beat or even a profound bradycardia when you count the pulses peripherally, while the electrical rate of the heart would be double that what you get at the wrist. Now think about the post-extrasystolic potentiation. The premature ectopic beat renders the myocardium refractory to the next scheduled beat, sinus impulse, resulting in a prolonged pause which gives adequate time for the diastolic filling, allowing the ventricle to fill completely to its maximum capacity. The subsequent sinus beat benefits from this massive ventricular filling and increased calcium accumulation by a phenomenon known as post-extrasystolic potentiation, resulting in a hyperdynamic bounding normal pulse wave that resets the pair again. So at the bedside, when you palpate, accurately evaluate a bigemini pulse profile. This requires distinguishing from a regular from an irregular pulse, and it should be distinguished from other irregular alternating rhythms which we will describe. So the golden rule for the diagnosis of pulsus bigemini at the bedside is simultaneous auscultation and palpation. You should place your steth at the apex of the heart while palpating the radial pulse. Identify the peripheral pulse deficit. If the premature contraction occurs very early, you will get a distinct pair of heart sounds in the apex, S1, S2, S1, S2, while the pulse wave outside would be exactly half of that. This discrepancy exposes the true peripheral pulse deficit. When both beats are strong enough to generate a pulse, you should train your fingers now to recognize a 1-2 tap followed by a distinct pause, then a 1-2 tap, of which the second of the tap is less in volume. Now the differential diagnosis that you should be considering with a pulse bigemini with other alternating irregular pulses is critical. So what are the common things that can confuse you? One is pulsus bigemini itself. This presents as an irregular pulse that we are talking about. It's driven by an alternating sinus and a premature ectopic beat, usually a VPC. And the defining clue is the interval between the strong beat and the weak beat, it's always short and followed by a compensatory pause. While in pulsus alternans, which is a rival that might confuse you, the features are perfectly regular rhythm driving and alternating severe changes in the myocardial contractility. Unlike bigemini, the time interval between all beats is identical and only the peak amplitude changes from beat to beat, and there is no pause. It's a regular rhythm. Another thing that can confuse is pulsus paradoxus. This manifests as a regular rhythm that shifts in volume based on respiration. So the moment the patient takes an inspiratory effort, there is a drop in blood pressure of more than 10 millimeter. This is reflected by a low volume pulse, and this normalizes during expiration. So first, do not count the pulse, do not count blindly, never rely on automated blood pressure cuff for the pulse rate. Don't do a quick radial pulse of 5 or 10 seconds and multiply. A patient with bigemini and a true electrical heart rate of 80 may present with a palpable radial pulse of 40 when it cannot generate an arterial pulse. Second, always confirm the underlying etiology because that is what defines the prognosis in this patient. Whenever a thing happens, rarely it can be occur, bigemini can occur via VPC commonly, but occasionally it can happen with an apparent conduction of a 3:2 Wengeback phenomenon block, but they are extremely rare. Always identify the underlying triggers because that is what determines the prognostication. Look immediately for electrolyte imbalance, especially hypokalemia and hypomagnesemia. Look for acute myocardial ischemia or look for digitalis toxicity if the patient is on digoxin.